We're going to go ahead and move on to the next session, and I'm going to introduce Dr. Laila Rashidi from Tacoma, Washington. Hope you're doing okay up there. We know that's one of the hot spots. She's going to be talking about understanding clinical value of robotics through data collection. We'll have questions and answers to follow.
Good evening. Hope everyone is doing well and keeping safe. My name is Laila Rashidi. I'm a colorectal surgeon at Multicare Healthcare System in Washington. Thank you for joining us tonight. I also want to thank Intuitive Surgical and Robotic Surgeon Collaboration for making this virtual forum happen. This evening, I'm going to be presenting my experience in the clinical value of robotic colon and rectal procedure through data collection. Before we get to the details, I just wanted to show you the snapshot of my robotic experience. I've performed about 450 cases since 2016 when I finished my fellowship, and my case distribution is listed below. In my practice, in general, I perform 90% of my colon and rectal resection robotically, and about 10% of these cases are performed in laparoscopic or open fashion. Today I'll be talking to you about data collection. But where did it all start? I'll start with a short story of mine that I think it will be helpful and puts things into perspective. This was one of my first adulthood, as you may say, hurdles in life. I was living in Iran. I actually finished my engineering degree from University of Tehran, and I wanted to move to United States. And it sounds pretty simple for a lot of people, but guess what? In Iran, this is not an easy task for a woman. There is a lot of steps in order doing that, both from a family perspective and social and socioeconomic perspective. I had to collect data. I had to show information to earn my way and prove that I could make it happen. So how did I make this happen? I had a goal. I knew what I want and where I want to get to. Did a lot of brainstorming, thinking about what I should do. And I had to come up with an action plan. But I had to make this plan measurable. I just couldn't say, hey, I want to do this. I had to obtain data, information, and based on those information, take an action. And with my action, show my family, my society, that I can make this happen. I can come to the United States and support myself and follow what I had in mind. It also required some patience. Sometimes we don't get what we want right away. And as you see, there's a lot of hurdles that can come in front of you. But if we have an action plan and if we have the information that we need to present, it can happen. And the conclusion is, I made it here to the United States, and I'm currently a colorectal surgeon. So why data? Why is it important? What is the value of the data? Why do we keep saying data, data, data? Well, data is a collection of figures and facts, is raw, unprocessed, and unorganized alone. Individuals and organizations can't do much with unprocessed data. So let's say if you have a bunch of numbers, which we call it data, and take it to your administration and say, hey, here's my data and I want this from you, guess what? That's not going to take us anywhere. So once data is given structured, organized in a cohesive way, and is able to be interpreted and communicated, that's when it becomes an information. And that's what's important. That's where it gets us to where we want to with that important information. Quality of the data refers to whether data is useful to make a decision, calculation, or any plans. And good quality data is reliable, it's accurate, and it's relevant, consistent and appropriate for given context. We need good data quality for effective decision making. So that's where the importance of data comes into play. Data has a lot of value. It helps us to understand what is happening and how in a particular situation, scenario, business, or reality using the power of statistic, math, and numbers work. It helps us to gain visibility to the unknown. It allows us to know what is our strength, what is our weaknesses. It helps us to support the need for a change in an operation or a process. It improves our decision making. It allows us to build stronger partnership with referral base and help to grow our practice. It helps to validate our cost avoidance and savings. It drives new innovation and technology. And it helps us to obtain best patient outcome. So take the data and make it actionable. I'm going to be talking to you about where data drove outcomes. This is my 2 personal case studies that I want to share with you guys. Hope you enjoy it. Case number 1, robotic colectomies not allowed. Problem number 1, this is a first job. There's no belief in robotic colectomies and this platform is prohibited. There was evidence that was needed. We had to demonstrate the cost effectiveness and clinical outcomes for robotic versus laparoscopic colectomies. Yes, it had its challenges. Number 1, I was pretty naive. I was a fresh graduate from fellowship, youngest of the group with the least experience, although I thought I had the world. So I started scheduling all these robotic colectomies, and soon after, I learned that the institution and my chief of division is not really in favor of robotic platform. And I noticed that no colorectal surgeon and even not many general surgeons are performing robotic surgery. And the main reason for that was high cost for the institution. So I had to formulate a plan, a response of how do I debunk and move forward? How can I overcome this problem? What data, what information I need to provide that I can get what I want to in my practice? Well, my first response was my own published data. I wanted to demonstrate how a higher volume surgeon can improve outcome and eventually decrease cost. This was my own published data that we compared high volume surgeons versus low volume, and we looked at operative time, length of stay, conversion rate, complication, and readmission rate. And we demonstrated that higher volume surgeons have decreased length of stay, lower conversion rates, and shorter operative time, which if you take all of these factors, it all equals less cost. So I was like, this is great. We're winning. I mean, this is a great response that I'm giving, and I can book any robotic cases I want tomorrow. But guess what? That was a pretty amateur response. We were still in the right direction, but I needed more data and more comparators to achieve what I wanted to. Case number 2. I was definitely more mature in my responses. I understood the hospital goals and plans. I discussed the case with the chairman of our institution and asked him for a 6-month trial period to compare myself with others in regard to short-term outcomes, such as length of stay, postoperative complication, etc., but also to compare cost and productivity between myself and others with different platforms. And based on the results, we can make a decision. He actually agreed to that plan. And that's where I started gathering my data, and I knew if I collect important, good data that I can formulate to an information and present to him, I can obtain and reach the goal that I have for my practice. This is an example of a data sheet I use in the operating room. A portion of this is filled out by our nurses, mostly the operational time, which I divided it to total versus anesthesia, consult time, time to doc, to kind of know in detail what we're doing, and also from our hospital course, any complication and narcotic use. Then I export that to my Excel sheet and my computer. And as you see, there's a lot of raw data here. And this raw data is what makes all the information and makes that data actionable. This table demonstrates the 6 month period we discussed about earlier. We looked at cost and short-term clinical outcomes between robotic and laparoscopic platform, comparing low anterior resection, right colectomies, and all colectomies in general. We found no statistical difference for total cost between right colectomies and all colectomies in general. We were cheaper in the low anterior resection robotically compared to laparoscopic approach. And we also found that readmission rates was much less in all three category in the robotic arm compared to laparoscopic. And looking at our operative time, we were slower in the right colectomies, and that I believe mostly because we do intracorporeal anastomosis in robotic platform versus laparoscopically, most of us still do extracorporeal anastomosis. And in all colectomies, there was no statistical significance, although we were a little bit higher in operative time in the robotic group. But interesting enough, in low anterior resection, we were faster in the robotic arm compared to laparoscopic. So as it can be appreciated, once you're passing that learning curve, you can be faster in the robotic platform with some good short-term outcomes and not much of a difference in cost. So that brought a lot of attention to my institution. So then I wanted to dive a little bit deeper and look at our robotic operative time and see if there's any opportunity to improve our efficiency. I looked at my average operative time skin to skin, which is shown on the left hand side for different procedures. And on the right hand side, it's showing the consult time. The consult time is pretty much the surgeon's time who's performing the operation. In my case, most of the operation is done intracorporeally. So when I get off the console, pretty much is removing the specimen and closure. But when we did the math and we saw what percentage of our operative time is consult time, we noticed up to 45% of the entire operative time is actually not operative. And the question becomes, what are we doing with this 30 to 45% of non-operative time? Is this anesthesia time? Is this our OR staff, docking, prepping, or is this educational base with resident and medical student? But I did find some weak spots that had room to improve. And that's where we started in our institution working on it to help with efficiency. So what was the end result? By mastering the data and making the changes, I was able to use the tools that I want from my own toolbox. I became the rainmaker for our division and became one of the busiest surgeons at our hospital. Most importantly, the value of technology was respected and opened up doors for other surgeons to perform robotic surgery without being questioned. And this is where I closed case number 1. Case number 2, no access to the XI. The problem was a little bit different. This was a new hospital for me, and they had the older version SI system. And administration did not see the need for upgrading to an XI system. And they were questioning, why should we switch from an SI to an XI? We had one XI robot and 3 SIs in our system. The evidence that was needed was demonstrating the XI capability in colorectal. Challenges. Of course, there's challenges. So in our case, there was no colorectal surgeon using the robot, so that was a little difficult to start with. There was no block time identified. Cost, of course, was a big issue associated with upgrading the system, and why outcomes are better with an XI platform versus an SI. So we had to build a case. I had to show what is the clinical value of an XI over SI platform to support the capital purchase. And this was again brainstorming what I need to do. Do I use my previous knowledge? What other data form I can use to convey this message? This table demonstrates short-term outcomes and costs between SI platform and XI platform. As you can appreciate, pretty much in almost every category, XI platform shows a benefit compared to SI. Operative time was almost half in the XI platform compared to SI, which itself equals cost. And as we can see, total cost and OR cost was much less in the XI platform. As far as other short-term outcomes, we saw a benefit in length of stay that was much less in the XI platform, and conversion rates. So with this data, we demonstrated that the XI platform has benefit compared to SI for colon and rectal resections. Building up on our case, I demonstrated that XI enables intracorporeal anastomosis in low anterior resection. The table below demonstrates the operative time and length of stay between the two groups. And as it can be appreciated, the intracorporeal anastomosis group had a shorter operative time and a shorter length of stay, very significant compared to the extracorporeal anastomosis group. And this all can be due to less tissue manipulation, less stretching of the mesentery, splenic flexure mobilization, which all could be related to increasing length of stay and definitely in operative time. To build more on our case, I compared my operative time and length of stay between robotic intracorporeal versus laparoscopic extracorporeal anastomosis in right colectomy. As you can appreciate, there wasn't much of a difference between operative time, at least nothing statistically significant, but my length of stay was almost half in the robotic arm compared to the laparoscopic arm. And that itself can contribute to my total cost for my patient in the hospital system when I'm performing robotic right colectomy. This was a pretty exciting data to share with my administration, showing them my shorter operative time with my colectomies robotically compared to laparoscopic platform, and proving the myth of longer operative time with the robot is not true. And once a surgeon passes their learning curve, they will become faster robotically compared to laparoscopic approach. So if you think all of this was enough, it was not. I needed some comparators. I wanted to show to my administration the difference between different surgical approaches. So we compared robotics to laparoscopic hand assist, laparoscopic surgery, and open. And by far, I'm not going to get into the details. You can see for yourself that our length of stay was less than 2 days compared to 3.5 days in the laparoscopic arm, with very low percentage of readmission and near zero conversion rate compared to others. That itself is cost saving. We are actually making money for the hospital with these patient outcomes. So by gathering and presenting all of these data, you're not only convincing your administration for upgrading to a newer platform, but also you're differentiating yourself to them. So by differentiating yourself, you're setting expectations. You're asking what other values you can bring to your hospital system. In this table, I'm demonstrating that not only we were doing elective cases, but we are doing emergent, complex, urgent colorectal cases robotically, and we're having as good as the outcome as we did for our elective cases. So, what's the result of this case? It was a team approach we had and the collaboration between different specialties and sharing our data, which helped to achieve our goal. We purchased 3 more XIs. And by sharing your data and showing your outcomes, your referral base goes up. As you can see in this table, just by being there for 1 year, my volume is about the same as other surgeons who have been in the area for a couple years. And we just became a case observation site for colon and rectal surgery. So there are hurdles, we pass them, and you can achieve the result that you want. Case study number 2 closed. So in conclusion, collect your own data. Be patient. Be your own judge. Data is powerful when it's translated to information. It is results driven, finding out what works. The top 5 surgeons can do things that the other 95% can't do in terms of improving outcomes and procedures, making better decisions based on advanced analytics as it's done, greater cost effectiveness on procedures that you do. Have a voice in a respectful manner and make changes despite your age, sex, or experience. I want to thank you for your time and for your attention and the opportunity to be part of this forum. Thank you.
Dr. Rashidi, that was a great talk, and I'm just amazed at the kind of surgical volume that you produced. The change management, I mean, you had chairs who were against you, you had institutions who were against you, and yet you were able to differentiate yourself. One of the great questions that Julie Thacker actually brought up on the comment feed was about the lost time. Again, all of us, as we get better operatively, but oftentimes the operative team and how we approach these cases needs to change even more. So how can you tell us a little bit more about that and what you did to change that lost time?
Yes, absolutely. I think one of the factors was, especially when I was at a university-based program, I noticed that the operative time was so long for the robot cases just because the name was robotic colectomy. And I noticed that a big portion of the operative time was going to anesthesia time from placing lines. They thought it's needed to place lines, from the teaching aspect. Also, just the nurses. It seems like, setting up for a robotic case is different and, from laparoscopic to open cases. And that's what we actually improved on. So it took so long just for our nurses and anesthesia, just getting the patient ready and set. That was a big one. And the other was, are we teaching too long, with our resident medical student? But that's the same. We do open laparoscopic robotic with the same peer, residents and fellows and students. So I didn't really see the change in that, but we noticed a lot of our time. And as you saw in my sheet, I divided it to different sections, from consult time to nursing time to anesthesia time. And we noticed a bulk of the time was going to those 2 aspects. And that's what we worked on. And it was actually pretty successful.
So cool. How about you talked a little bit about the XI platform, and again, can you just describe why was it so much better than the SI? What was game changing about that for your practice?
I think the game changing was mostly, especially for our rectal cases, not using 2 platform, doing the splenic flexure, for instance, laparoscopically, and then docking back and doing the rectal portion with the robot. The intracorporeal anastomosis, that actually was a big changer for me personally. I rarely have to do splenic flexure mobilization, just because we don't have to mobilize as much to make that phanestal incision and bring the, colon out and put your anvil in there. And I think, that was one of the big changes. And just the multi-quadrant, I do my total colectomies not total procto, with just one docking, with one setting. So that itself, as you saw, I'm actually faster doing a robotic total colectomy than my laparoscopic total colectomy. So I think the XI platform, from a multi-quadrant aspect and availability, will help us, achieve the operations we want.
So cool. Eric, would you like to ask a question?
Sure, sure. That was a great presentation, Laila. So I want to take it back again because I thought that was fascinating when you really looked at the console time versus the OR time. And I did the very same thing several years ago when I was kind of starting out, and I noticed the very same thing. I was spending 20, maybe 30% only of the entire OR on the console. A lot of that was me more than anything. And as I became more comfortable with the robot, we kept going and going and going. The ultimate, I think, is we're going to talk about tomorrow, doing some transrectal extraction in ICA, because our robotic time versus the total time is about 95%. It's all robot. And I think that's something, the higher percentage of robotic you can do, the more efficient and the quicker I think your cases will go. So you brought up a great point. I think we're going to talk about it tomorrow. But I do want to ask you, so if I were to go to my chair and say that I want to compare Haas versus colleagues, they're going to show me my data, but they're not going to show me my colleagues in my own institution. And a lot of institutions may or may not be like that. So they basically say, you could look at yours, but we're not really going to let you look at others. Did you find that to be a problem? And if so, how could you overcome that situation where you're not really privy to others people's outcomes?
I think the big key was I didn't use any identifiers. We looked at all of our colorectal procedures. Number one, when I went to my chair and said, hey, let's just do a comparison, it wasn't to do a comparison that I'm this and the other, surgeons are different. It was just showing that how we can improve the quality of care, how we can decrease the length of stay, and how we can actually save money. Kind of discussing about the use of the robot. So when I started, I actually said, I just want to compare myself with any colectomies that's being done in our institution. So they didn't feel that they have to give me names. And when we did the comparison, they were initially de-identified, but then we came and looked at just with colorectal surgeons, the ones that do robotics or do not do robotics, mostly comparing laparoscopic and robotics, because I think open right now we shouldn't be even comparing anymore. And that was the agreement between all, because we were fighting for the same reason, since no one in the institution could use it. And I think that was the key. And in my recent hospital, I really didn't have this problem. I mean, they gave me the data. I don't have it myself, but we were able to obtain it.
Laila, a quick question about, I'm a big believer in transparency. We show data for everyone across the board, and I don't believe it's really a shaming exercise. It's really an opportunity to elevate everyone's game. So as you started to do this, I would guess that this was new for your group. But
Yes.
as you started to show this data, did you convert other people in the group towards what you were doing?
I have to say I did. Once they saw, I think once you see your length of stay, once you see how well, I mean, we have patients that leave day one or sometimes less than day one. I mean, if you think about it, we finished the operation in the afternoon and they're leaving early the next day. So this is less than 24 hours. So, and they do very well with, you saw not much of a readmission rate, is very low, and no conversion rate. Versus in the laparoscopic group, both hand assist and straight lap, there was a lot of conversion. So we are making changes. Yes, we did. In my last institution, we did convert a couple people to robotics. And in this institution, we're working on it as well. So definitely, the surgeons, when they see the outcome, I think just going and saying, hey, robotic is a great tool is not enough. You have to have evidence. You have to show them why is it better. One of the reasons I got pretty busy very quickly was I showed my data. I went and spoke to gastroenterologists, to primary cares, and told them what I do with the outcomes we have. And patients talk. I have referrals from my own patients. So that's how you can make the change, I believe, within your institution and within your practice.
That's right. And Laila, I'm going to tell you, it's more than outcomes. It's what you said. It's also marketing yourself and getting the word out there. And of course, as you do more surgeries, your patients are going to become your best advocates. There was a question on the comment stream saying, who was it that put all this data together? I mean, you were in the OR, you had your sheets, you're obviously working with the nurses. But at the end of the day, were you doing this at home? Did you have a research team? How does the typical person get all this together?
For my own data, I do it so as far as the timing, all of those are documented by our nurses. And I have to tell you, they're great. They know we have the huge pack of those papers in the operating room. So every case we bring it out. I fill the rest of the portions, which I actually have it on my Excel sheet, but from an operative time standpoint, they're very precise. They write everything down. So we pretty much trained them, to follow these guidelines. As far as entering them for my own, I enter it myself. It may take a little bit time. Actually, it doesn't anymore once you get used to it. Initially, it was taking me. Then you find your way. I mean, I have my computer all the time with me. I mean, I have the patient MRN, in there with, all the information I need. And I just enter it. And every week I go back from length of stay or complication or whatever that has happened. I fill in the blanks. Their pathology came back because we're looking actually from our outcome standpoint for cancer patients, our circumferential margin, our pathology, multiple aspects we will look at. And I would tell you, maybe max it will take an hour if you have a full pile. It doesn't take that long. And then putting them all together, yes, resident, students, our research team. So that's where, the data, when it comes together, it's being collected and analyzed.
Well, very, very good. Well, fantastic for that presentation. Great question and answer session there. It certainly goes to show that it takes a lot of hard work, both inside of the operating room, but then outside as well, to try to make a case for your platforms and your technologies. Thank you very much.